Welcome to the 3Ds lecture. My name is Jordan Rose. So we're going to be talking about dementia, delirium, and depression today. In the weeks to come, we're going to focus a lot more on depression, but this week we'll just talk about how depression can have symptoms that are similar to delirium or dementia. And so it's important to think about that as a differential when trying to work up a patient that is showing signs of confusion. The majority of this lecture is going to focus on dementia, but we will talk about how delirium can be very much the same thing, except that delirium tends to be reversible, whereas dementia tends to be progressive cognitive decline. So what is quote-unquote confusion? Unfortunately, it's a term that is often misused to describe one of these three conditions: dementia, delirium, or depression. Confusion itself is a symptom of an underlying disorder. So dementia can range from mild to severe. Patients are often unable to express their thoughts clearly. They often have bizarre behavior, could be behaving in an aggressive manner. Sometimes there's trouble with problem solving or completing simple tasks. A patient cannot know where he or she is. Sometimes they are unable to recognize family members or familiar items. They can sometimes express very firmly held but false beliefs, so delusions of grandeur. Sometimes they can hear, feel, smell, taste, all the senses, things that aren't there. That's also known as hallucinations. I once had a patient tell me that she saw rainbow fish swimming on the walls, and she was dead serious. And she thought that was an improvement over the previous hallucinations she had on another medication that I had her on, and so at least the fish made her happy. So we stuck with that for the time being. Then also there could be believing that others want to harm them, which is known as paranoia. And there could be a diminished ability to remember things or think clearly. So by definition, dementia is a combination of two things essentially. It's a memory dysfunction and at least one additional cognitive deficit. So like apraxia would be the inability to carry out tasks. Agnosia is the inability to recognize faces or objects. And executive dysfunction is along the lines of maybe inability to make change when you're dealing with money. If you pay a certain amount, they can't figure out how many coins to give back. Difficulty maybe following a recipe, doing something that follows like a sequence that requires some sort of previous knowledge. They start to lose the inability to do those tasks. Now, there's also cognitive disturbances, and these are severe enough to impair occupational functioning. So a good way to assess this would be to ask a patient how they are performing their ADLs. And these need to represent a decline from a previous level. And so it's oftentimes very helpful to have a family member in for the office visit to be able to provide better history. Sometimes the patient is unable to really give a clear history, and so the family member can tell or answer your history questions, and then also be able to provide some insight on how the patient happens to be progressing in terms of their cognitive function. So whenever you're thinking about quote-unquote confusion, dementia should of course be at the top of the list. Some of the other possible causes of these symptoms would be Alzheimer's disease, which is a dementia. And that's pure Alzheimer's, could be 40%, a mixed would be 70% of the cases. Vascular disease accounts for up to about 5 to 20% of the cases of dementia. Drugs, depression, and delirium are definite other possible causes of the symptoms. Ethanol, which is alcohol, can definitely cause some of the symptoms. And then metabolic disorders, so you would be thinking things like B12 deficiencies or some folic acid deficiencies, something that might be spurring these symptoms of confusion or cognitive decline. Other things, diabetes, if people's blood sugars are continuously high, it can give them like a diabetic brain where there's some fuzziness, confusion. Thyroid problems, hypothyroid can be a problem as well. Changes in the environment can definitely cause people to have either temporary kind of situational confusion or even more severe. There are other things like toxins, tumors can cause changes in personality, can cause confusion, and then infection. In the older population especially, that can be one of the number one causes of a sudden change in cognitive function. So anytime a patient shows signs of being confused, and up until that point they've been very, very clear, you might want to automatically think of a possible infection being present. And then there are also some other things like apnea, autoimmune disorders can cause some symptoms of confusion or cognitive disorders. So the Alzheimer's type of dementia accounts for about 50 to 70% of the dementias. So this really is the most common cause of quote-unquote dementia, the official dementia that is not something that's reversible like a delirium might be. Depression can affect up to about 15% of the elderly as well, and some of the apathy seen in depression can mimic symptoms of dementia as well. But with the depression, there tends to not be a cognitive impairment in the same way that there is seen in dementia. The course for dementia of the Alzheimer's type is a gradual onset and a cognitive decline. And the deficits are not due to other central nervous system conditions, substance-induced conditions. This is truly a change in the structure and function of the brain itself. And it's not due to some other psychiatric disorder like depression. There is a vascular type of dementia as well. That affects up to about 20% of the persons with dementia. Interestingly, in Japan, that affects up to about 50% of the persons with dementia. The main focus for this one, just think cardiovascular here. It's just like a stroke or a myocardial infarction. The goal is prevention. So you're thinking about doing things like stopping smoking, starting a baby aspirin, precise control of hypertension and cholesterol. Ideally, you just want to decrease the cardiovascular risks. And the way this works is the dementia is due to an interruption of the vascular supply from either ischemia or thrombosis. And the presentation depends on the affected areas of the brain. It can present with mild symptoms over time that the family doesn't quite recognize. The PET scans can oftentimes show some areas that that should be affected, but the PET scans don't always correlate with the amount of dementia. Some people could have fairly scary looking PET scans and still be fairly functional, and the opposite it could be true as well, where the PET scans look not too bad, but the patient could be experiencing significant changes. Unlike the kind of gradual, smooth onset of the Alzheimer's, the damages here tend to be a little bit more sudden. So it's more of like a stepwise presentation where there's a little drop in cognitive function and then boom, another drop in cognitive function. So, like I mentioned before, it tends to be a stepwise deterioration. History of stroke can be a major concern or risk factor for this, because you know that there is already a certain amount of cardiovascular problem in the brain, and so that ischemia that's going on that causes a stroke could also be causing some of the vascular or multi-infarct dementia. Depression, which is oftentimes seen in the left anterior strokes, can also be present at the same time, because once you have these strokes, it could affect the overall dementia, but it also could be causing the depression that can commonly be seen in those left anterior strokes. Personality change can occur as well when there's damage to parts of the brain. There can be a change in how a person's mood and behavior occurs. This one tends to have more gait problems than Alzheimer's disease. The strokes tend to or can affect the areas of movement in the brain. There's such a thing as Binswanger's disease, which is essentially the same thing as a vascular dementia, but just a variant of the multi-infarct dementia. And so if you feel like it, you can look that one up, but you're probably not going to need to remember that name. just remember overall what the risk factors here are and best ways to prevent, and then be on the lookout. If you are having patients with some of these risk factors, this could be a possible cause for mental deterioration, so keep a lookout. The neuropsychosocial dysfunctions are patchy, so depression and agitation and some of those symptoms can possibly be present, possibly not be present, and it really just depends on the patient and the type of vascular damage that is occurring. After cardiac surgery, 53% of the patients have post-surgical confusion, and that can actually last for years after. 42% are still impaired 5 years after their cardiac surgery. And so they're thinking it might be related a bit to an anoxic brain injury, when during the surgery there just is not enough blood getting to the brain. Apnea, and it also may be related to narcotics or other medication post-surgery. The other risk is, of course, genetic. Would this have occurred in patients, in those patients who would have would these patients have developed dementia anyway, and was it worse for those specific patients? So if that's the case, should we be doing some kind of screening pre-cardiac surgery? And then, of course, if we were doing the screening, then the question is, what would we do to prevent the dementia from kicking in? At this point, we don't really know. So I guess saving the heart is more of a benefit than a risk at this stage of the game. So just remember that the effects on the brain are very similar to the effects on the heart when there is cardiovascular disease present. And then also just post-op, being in a different environment for some of these patients can definitely have a situational effect on their cognitive function. There could be a situational or transient delirium or symptoms of cognitive dysfunction. Another cause of some of these symptoms would be drug-related, and that includes both regular drugs and illicit drugs. The anticholinergics, surprisingly or unsurprisingly, are known to be linked to issues with cognitive decline. Think of all the over-the-counter medications that people just have daily access to, such as diphenhydramine and many of the antihistamines. They can cause things like blurred vision. They can cause visual disturbances, dry mouth, constipation, urinary obstruction, and all of these things can be symptoms of dementia. They can also cause confusion or a memory block, especially with some of the lethargy or the sleepiness associated with the diphenhydramine. Some of the others are like the benzodiazepines, barbiturates, beta blockers. At least the old ones, the non-selective beta blockers, can definitely cause confusion or depression. So that would be a medication that if you were concerned about a patient who showed up having signs of confusion or dementia, you might want to switch to something a little bit more selective. And then definitely narcotics can contribute to dementia, if not at very least delirium during the use of the narcotics. So you just have to remember to be very alert of these medications, and you want to reconcile medications anytime one of these patients comes in. If you are concerned about their mental well-being and their cognitive well-being, make sure that they bring their medications in like a brown bag and have them explain to you every time they come in for their visit exactly how they're taking their medications, to try to limit the amount of possible polypharmacy or over-the-counter use that could be contributing to their symptoms. So depression can have some symptoms that definitely mimic certain symptoms of or are similar to symptoms of dementia. Dementia can sometimes present as apathy, and so can depression. Depression affects up to 15% of the geriatric population. It's especially commonly seen in certain groups, most significantly in groups with debilitating chronic disease. It's amazing how many patients that have developed a chronic debilitating disease form depression. So I say, instead of screening once a year or once every 2 years, when you have a patient walk through that door that has a debilitating chronic disease, is over a certain age, maybe like 55, 60, I would screen these patients for depression pretty much every time they are coming through the door. And you can do something like a PHQ-9, or some EHRs have just a quick questionnaire that's part of the vital signs, like if they're having any depressive thoughts or feeling blue. It depends on the EHR and the facility. Sometimes they have standard questions that they ask. So depression has a much more rapid onset than some of the other disorders that we've talked about so far. It's much more rapid than dementia, but not quite as rapid as delirium would be. Delirium tends to be very sudden, and so that can also be an indication that something is going on underneath the surface if the cognitive decline kicks in right away. So some of the precipitants are psychosocial. It's not as much organic. So it can be things like the death of a loved one, a new medical diagnosis, a loss of independence. Those things can contribute to an onset of depression. The mood tends to either be depressed or anxious. There can be decreased activity or agitation, which of course sounds similar to some of the signs of dementia. The somatic symptoms, such as fatigue, the lethargy, the sleep and appetite disruption, that you need to really kind of suss that one out. You need to think about, is this secondary to depression, or is it secondary to some kind of illness? Is it secondary to the medications they're taking? Is the polypharmacy making them feel lethargic and interrupting their appetite? Or is it depression, or is it some kind of urinary tract infection or something along those lines that's causing the appetite and all of the fatigue to kick in? So just anytime you see a rapid onset of the cognitive decline, you really want to kind of perk up and think, okay, rule out the things I can rule out right away. This can be difficult to diagnose just because the family might not want to report the depression due to the stigma surrounding the depression. There might be feelings of guilt. There might be some kind of cultural influence where, due to the culture the patient happens to be from, that the depression isn't accepted or it isn't recognized, and therefore it's harder to really figure out and treat. So depression is especially common. It's in patients that are over the age of 70 and hospitalized. So if you happen to come across a patient like that, immediately you want to be thinking, okay, depression, depression, depression. Is this a patient that could be suffering from depression? There's usually a medical comorbidity present. At this age, obviously, there probably is something going on. I mean, once you get to 60s and 70s, most people have at least some kind of medical issue. 30 to 60% of patients who've had a stroke are depressed. Patients with coronary heart disease, about 8 to 44% are depressed. Patients who suffer from cancer, obviously there's a pretty significant amount of depression, up to about 40%. Parkinson's is also around 40%. Alzheimer's is around 20 to 40%. And then other dementias such as the vascular dementia or the dementia of chronic disease, that's around 17 to 31% of those patients also suffer from depression. So sometimes it's not even just one thing. It's not just dementia, but it could also be depression as well. So it's just really important to think about, could more than one thing be going on? Don't just immediately write the symptoms off, like the symptoms that you're seeing that could be from depression. Don't immediately write them off as symptoms of dementia just because you already know a patient happens to be demented, or vice versa. If you know a patient is diagnosed with depression, don't just write the symptoms off as, oh, that's their depression symptoms. You might need to really do a workup for the dementia. So anytime, basically, the key here, when an elderly patient presents with confusion, please screen them for dementia and depression. So the really key thing to remember also about late onset depression. So when a patient up until later on in life just has had no signs of depression, and without any other precipitants, there isn't something that just happened in their life, like a partner died or something like that. If a patient previously has not been depressed, nobody has recently died, there aren't any major changes in their condition, and suddenly now they are developing depression, that could be a red flag for a possible dementia or Alzheimer's. So if there's a late onset depression and without some kind of precipitant, please do think about possible dementia or Alzheimer's. So moving on to delirium, this is also, delirium and dementia are oftentimes identical in their presentation. The key being delirium is something that's temporary. It's a sudden onset, typically temporary, and it's typically due to some kind of underlying cause. There's a change in the cognition, such as memory, orientation, language perception, and then it can show up in a matter of hours or even days. The key here is you have to find out what the cause is. The changes in environment can lower a patient's threshold for delirium, so patients that are in a hospital setting can show signs of delirium that they hadn't otherwise ever shown, and it's just because the environment is so different to them that kind of pushed them over the threshold and brought those symptoms out. They can be worse in the evening, such as sundowner's syndrome, and so you do want to screen for dementia as well, because patients who do develop delirium can be predisposed to full dementia as well. Just remember, with delirium, you want to rule out other conditions that could be causing it. So delirium is acute, it's transient, and it's typically due to the underlying cause that could be along the lines of drugs, hypoxemia, it could be infection, it could be due to trauma. And so some of the things that could bring out the delirium are age, dementia, infections such as a urinary tract infection, pulmonary infection like pneumonia, a GI disorder such as constipation. These symptoms can bring out these disorders can bring out the symptoms of delirium. Oftentimes, elderly patients don't show the typical signs of a urinary tract infection. They don't have the dysuria, they might not have the frequency. They might show more along the lines of shakiness, a little weakness, a little bit of confusion. They might have some incontinence. So anytime you have a patient that's coming in feeling a little weak, maybe a little shaky, possibly a little tired or lethargic, confused, think about things like urinary tract infection, pulmonary infection, things that can eventually become systemic and really do that poor patient in. Drug toxicity, so are they taking all their medications correctly? Did they happen to misuse or overdose or accidentally take the wrong medication? Are they taking other illicit types of drugs? Injuries, falls, bleeds, fractures, these can all lead to delirium. If you happen to see a patient come in with delirium, when you're doing your physical exam, I really want you to take the time to look at their whole body. I want you to look for signs of possible physical trauma that could be indicating maybe abuse in the home. You need to be an advocate for these patients. For people that are already diagnosed with dementia, it can be easy to attribute the symptoms of the delirium that they're experiencing to the dementia. So I want you to be very good clinicians and don't just immediately jump to what you think is the answer, which is the dementia. Anytime a patient comes in and is exhibiting these symptoms, and there might be a change from what is normal or what they're used to, you definitely want to do that history. You want to find out, is something new, is something changed, is there possibly an infection present that could be causing that change in the symptoms. Don't just see a patient with dementia and immediately think, it's just the dementia kicking in again. You really want to be sure to work it up. Ethanol can definitely have an effect on a person's cognitive function. So ethanol is alcohol. The other things that can do it would be accidents, head injury. This has received a lot more focus for those who watch football, professional American football. There are quite a few cases of repeated head injuries that caused actual post-concussion syndrome and brain deterioration, and those patients were experiencing signs of or symptoms of dementia later on in their lives that sometimes ended far too quickly. Other things that can cause signs of delirium or dementia would be a dietary deficiency, such as a thiamine deficiency, or the Wernicke-Korsakoff syndrome. So you want to ask a patient to do a 24-hour dietary recall. Are they only getting their calories from their alcohol, or are they getting calories from actual food? The concern with the alcohol use, the chronic alcohol use, would be hepatic encephalopathy. Are they building up too much ammonia in their systems? Or are they having problems clearing or filtering their blood properly? So you'd want to do a liver function test for those patients. Think about the alcohol withdrawal too. There could be seizures that could be mistaken for dementia, or they could be having withdrawal symptoms that are mistaken for a change in behavior and aggression, And so if these patients happen to come through the door in your clinic or in the hospital, be thinking, okay, is this change in cognitive function due to some kind of underlying cause, such as a progress or progression toward maybe going into DTs? And if that's the case, you're going to need to get them hospitalized right away. You can see in this picture down to the right the difference in the gray matter of a patient who is a kind of a control. It's a standard patient, and then a patient who uses alcohol chronically. And so you can see that there is less gray matter present already in patients that abuse alcohol. And so there's some thinking that if there's already less gray matter, if dementia were to be kicking in or to occur, that there's already less gray matter to deal with, so further deterioration of that gray matter might actually speed up the progression of the dementia. Other things to think about for delirium would be medical causes or endocrine problems, such as the thyroid dysfunction. And so you would want to do not just a TSH, but also you'd want to do the T3s, the basically a thyroid panel. So you'd like the T3, T4, just because certain elements of those can actually, when they're off, cause these symptoms of delirium. Other things that can do it, like I mentioned before, really high or really low blood sugars can cause a change in your cognitive function. If they have any vitamin deficiencies, such as the B12, thiamine, niacin, there could be a pernicious anemia going on here. So you can do a test for either B12 or the homocysteine, like was discussed in the hematology lecture. So again, just whenever you have a patient coming in with delirium, you really want to start thinking about possible underlying causes here. Because the nice part about that is it's treatable. You can hopefully resolve the symptoms that are associated specifically with the delirium. Unfortunately, if they have dementia as well, we're not going to be able to resolve those. But in terms of the acute delirium symptoms, by treating the underlying cause, we can typically cause those symptoms to resolve. Just here you want to make sure, I mean, I feel like I'm beating a dead horse here, but always get a good, thorough history. Pretty much any disorder you're trying to work up, you want to get a nice, thorough history. That's one of the keys, but especially here because sometimes there aren't too many tests that you can do. You can do some of these lab tests. You can check. One thing I didn't mention here would be to do a urine test, a UA, to make sure there's no UTI going on. If they were having cough-like symptoms, you would also maybe consider doing an X-ray, chest X-ray, to look for pneumonia. So again, you're looking for those underlying causes. You do the lab tests or other scans as appropriate, and try to turn around or fix whatever the underlying cause might be. So, even though it doesn't necessarily cause dementia, there are certain sensory deficits that, if present, can make a patient appear to be having symptoms of dementia. So loss of vision in the elderly population is a major health problem. About 1 in 3 people have impairment in their vision by the age of about 65. That's 1 in every 3. By the age of 70 or 75, that number is even higher. The decrease in vision can possibly lead to a decrease in the ability to perform activities of daily life, those ADLs. That loss of independence, that inability to function socially or perform some of the abilities and skills that you used to could possibly lead to an increase in depression, and that increase in depressions could also lead to then an increase in depressive and symptoms such as that are similar to the dementia and delirium. Common causes of eye health problems would be glaucoma, there's macular degeneration, there's diabetic retinopathy. So all the more reason when you see a diabetic patient, you want to get them in with the ophthalmologist right away, and every time you see them, you're checking to make sure that they've had a recent eye exam within the year. The cataract, luckily, can be fixed with surgery. But unfortunately, surgery then, of course, can cause symptoms of delirium. There can be medications that the patient's taking. There can be pain that can cause the symptoms of delirium. And then, of course, the vision change after the surgery could also cause some coordination issues, or cause a change in perception of the world around. So all of those things, even though it helps to improve the cataract, could also lead to at least a little temporarily more symptoms of dementia. So again, because the eyes are so important to how people perceive the world and their ability to function within that world, I would recommend an annual eye exam after about the age of 65 for anybody, even if they don't previously use glasses, or if they don't really have too bad of a prescription. I would still say just get an eye exam every year, just to make sure there haven't been any changes that could put these patients at more risk for becoming isolated and not being able to perform their ADLs, or that could be contributing to some of their confusion or cognitive decline. You need to use your eyes for some of that mental stimulation. So there are also some neurodegenerative diseases that can lead to the symptoms of dementia or delirium. There are things like the cortical atrophy. There's the primary progressive aphasia. There's the unilateral atrophy. And so you're probably going to, when you do a PET scan, if the patients can even afford to do these, you do PET scan and you might see some hypofunction on like one side or the other of the brain. The frontotemporal dementia is due to the tau gene. We're gonna talk about that a little bit later. And then of course like the Lewy body variant, and that's due to the nigral cell loss and the plaques and tangles. It's all of these essentially lead to degeneration of the brain matter and inability to function cognitively like previously. The normal pressure hydrocephalus, that one tends to be like dementia with a gait impairment and incontinence. So just remember that triad. If there's problems with gait, incontinence, and dementia, you want to have hydrocephalus be high on your list there. That's kind of the standard triad. So other possible things would be along the lines of like a tumor or trauma. You see that in the picture down there. There could be a tumor that's putting pressure on certain areas of the brain that could be causing changes in behavior, mood, cognitive function. And then of course I just want you to remember, whenever you're doing a physical for these patients, physical exam, you also want to be checking for trauma. Did they have a recent fall and have a brain injury, or is there abuse going on in the home? So just remember, when you're laying hands on your patients, always just do a quick scan for, and this is on various, like the whole body. The trauma could not just be brain, but there could be some abuse going on at home that and the pain is causing there to be some other problems. That wouldn't be necessarily a neurological dementia, but still it could lead to demented symptoms. And then we've talked about it a little bit before when we were talking about the delirium, but there are various infectious conditions that can affect the brain. And some of them could be on the viral side, such as herpes, HIV, and then there's things like syphilis and then meningitis that could also be causing these sometimes vague symptoms. The syphilis tends to be kind of the late stage syphilis where you start to see neuro decline. It's very, very interesting. I actually had a patient come in that he was just too young to be having signs of some dementia, and he didn't have much in the way of a family history of dementia either, but he had been. I finally was able to kind of get out of him that he had been in jail a year or two prior up in Oregon, and when I talked to him a little bit more, it sounded like he was having some skin issues in the past that he was thinking and had been told were related to MRSA. But I did a culture on one of his sores that he said he had, and there was no bacteria whatsoever. So I did an RPR, and it turns out he had some later stage syphilis, so we had to treat for that. Anyhow, and then like mad cow disease could even be causing a little bit of some changes in cognitive function. These are all things to consider. Probably the most common infectious issues are more along the lines of UTI or pulmonary infections instead of some of these, but it's still worth thinking about when you're doing your workup. Okay, so there is one other thing called amnesic disorders. These epilepsy can be a big contributor to these. So can MS. So can the Wernicke-Korsakoff syndrome, in which the thiamine deficiency and the hypoglycemia can lead to hypoxia. The epileptic events can cause some partial complex seizures. Patients may or may not be aware, and then there could be some confusion, lethargy, other problems afterward. And then certain brain diseases, like I mentioned, multiple sclerosis can definitely be a problem. So these are fairly rare. I wanted you to be aware of them, but these are not going to be high on your list of differentials. This would be kind of the last part of the list. If you've ruled out everything else and you're still sure that it could be due to some kind of other thing other than like an Alzheimer's or a maybe a vascular dementia, then you could think about this as well. So, age, unfortunately, we cannot avoid, and it is associated with memory impairment. As you age, unfortunately, there are some changes that occur in your brain. I know that I often do this where I happen to walk into another room and I cannot remember why the heck I went into that room. Luckily, if you're not doing this on a very regular basis, this can be pretty normal. Anyhow, whenever a person ages, there is a slight decline in cognitive function. If you have a patient coming in and asking you or saying that they're worried about memory loss, that they're worried about some possible cognitive decline, not being able to remember things, it can be a really hard conversation to have, and it can be hard to figure out what exactly is going on with the patient too. So if a patient does come in and say that they're worried about memory loss, some of the things that I like to discuss or say or mention to them, there are several reasons for memory loss. Age is usually the cause. Information is stored in 3 parts of memory. There's the short-term memory, which is something like a person's name that you just met. And I'm terrible with this one, so I've always had a problem with this. So I might not be the best way to see. I might not have it might be hard to determine if I have any signs of dementia based on whether or not I can remember names, because I've never been very good at that. There's also the recent memory, and that is along the lines of remembering or recalling what you ate for breakfast. There is also remote memory, and that's along the lines of remembering what you did in your childhood. The beginning at the age of about 20, you start to lose brain cells. Unfortunately, that's just the way it is. You also tend to make less neurotransmitters, and that can actually lead to changes in the way you store and retrieve your memories. The short-term memory and remote memory are usually not affected by age. It's too significantly in a normal person or a normal case. Recent memory, though, can be affected. But slight changes in this can be normal. What tends to be abnormal is forgetting things often, or forgetting how to do things you could do before, but suddenly you're not able to do them now. Unable to learn to do new things. That can be a sign that maybe there's something abnormal or more significant going on. Repeating phrases or stories in the same conversation. My mom is super good at doing this. I will have a conversation with her in the morning, and then I'm talking to her, and we happen to mention something that kind of seems similar to what that conversation was in the morning, and she'll tell me that same story again. She loves to repeat that. She likes to say it's because she has so many kids that she can't remember who she told the story to, but who knows? There might be something else going on. I'll give her the benefit of the doubt for now. Trouble making choices can be a sign of an abnormal change, and then the difficulty handling money, like I mentioned before, inability to make change with the money. Those are some skills that require some real cognitive thinking that tends to go when there are real concerns or real possibilities of an abnormal cognitive decline with age. So this table shows what's normally expected in normal aging, so kind of the benign forgetfulness, the not so harmful forgetfulness, and then the changes that are not really consistent with what's expected with aging, and that tends to be more of the abnormal variety. So normally a little frontal lobe decline means maybe some memory lapses, but your ability to perform your activities of daily life are spared. When you have the mild cognitive impairment with symptoms that kind of fall in between these benign ones and the ones inconsistent with expected changes of aging, then that could mean a risk for the dementia or Alzheimer's. So if you kind of are seeing a little bit maybe of both of the lists, then you might want to be a little bit more concerned something more significant is going on. If there is impaired function, so maybe some changes in ADLs, then you're thinking, okay, more along the lines of the neurodegenerative dementia. So like I mentioned at the very beginning, that's a decline in two or more cognitive domains. In early Alzheimer's, you're dealing with things like difficulty retaining information, difficulty jogging memory, social withdrawal, or mood changes. But as things progress, then there tends to be there are things more along the lines of word hesitancy or circumlocutions. It's called circumlocutions, where they use a ton of words to try to say something. Though the language comprehension at this point in time is less impaired. So you want to assess the cognitive function for these patients initially with their ability to perform their ADLs. So are they still able to get out shopping? Are they still cooking? Are they managing their money? Are they using the telephone? Or how are they taking their meds? If they're still functionally able to do those things, then you're going to be monitoring closely, but you might not be immediately kicking in with some of the PET scans and things. But if you're noticing that some of those things are starting to change, like they're needing their kids to do some of the shopping for them more, or they are sometimes finding that they're leaving stoves on, or they are struggling to monitor the money that they're using, that is now more of a sign that there is an issue going on. And this is where having the family available is really important. Sometimes the patient doesn't even really fully recognize or admit or want to own up to the fact that these changes are taking place. So you may need a family member to give you some point of reference, like, oh yeah, 2 years ago she was kicking butt, she was doing all these things really well, and now I've noticed that she just doesn't really get out of the house much, or she is not able to go shopping anymore, and she's doing more just like frozen meals as opposed to cooking these recipes that in the past she was able to do, or something along those lines. You just want to try to get the family involved if you can. So in America, there are about $1 billion in costs each year due to Alzheimer's disease. So it's a huge financial strain. It also causes major stress among the caregivers, so it's an emotional and psychological strain. Also among the families that want to maybe provide care for the patients, but sometimes the care required is beyond their skills or means. So this is a really significant problem in the elderly population in the United States. So the key, uncovering the etiology, finding out what's really causing this dementia or the Alzheimer's disease, the reason that's important is it will help us develop better pharmacotherapies. Better understanding the pathophysiology is the same way. Is there a place that we can intervene with a new drug that might be able to slow or even possibly reverse some of the changes taking place? And they're always trying new things like stem cells or even vaccines and new drugs. So hopefully in our lifetime there will be some progress where some of these things can not just be maybe slowed, but either halted, or what would even be more fantastic is reversed. Unfortunately, we don't have any of that right at this moment. Better screening tools are continuing to be developed. The gold standard now is kind of the mini mental state or mental status exam. That one, I would, if you don't have it already or don't know it already, maybe make a little cue card for it. Anytime you're concerned about cognitive function, even after something like a concussion, you're using that exam to see if there's some kind of impairment going on. Diagnosing earlier is the key. The earlier you diagnose, the more options you have. There are better meds that can be used. There are the earlier access to meds means that they can be started sooner and hopefully slow the cognitive decline. There can be better discussions with the family about things like power of attorney and future plans and desires, resuscitation status. All those things can be discussed, hopefully, if the patient is still pretty cognitively functional at that point when these discussions take place. So ideally, if you catch these things earlier, you just have more options to treat and to make the life for the patient and the family and the caregiver easier. There are about 491,000 new cases expected in 2020. About 1% of the people ages 60 to 65 have Alzheimer's. About 2% of the patients ages 65 to 70 have Alzheimer's. About 4% ages 70 to 75. And about 8%, so now we're starting to really get up there. I mean, that's about 1 in 11 people,
ages 75 to 80 have Alzheimer's. And then once you're above age 80, you're up to about 80, 85, you're up to about 16% of the population. So really there are more and more drastic jumps the higher people get in age. So in terms of the etiology, as we age, our brain becomes less able to repair itself. Neurons die, and the ability to use the brain is also affected. Some people might have higher levels, so in terms of the genetic element, the amyloid related element, some people have higher levels of beta amyloids, and the beta amyloids end up leading to more plaque buildup, and this affects the ability of neurons to function. You can see up in the picture above how there tends to be these neurofilaments that work their way and accumulate toward the terminals, and then they start to cause this twisting almost, tangles, I should say. So there tends to be this plaque and tangle that develops, and these definitely affect the ability of the brain to function and the neurons to function properly. In terms of education, that is also a factor. So using the thought is when you use and develop your brain, when you're studying and learning and using your brain in a complex way, then that tends to cause more brain activity, which causes more modeling and possibly causes more creation of more neurons. And so the hope is that if you have more neurons from the get-go, even if there does happen to be cognitive or problems happening to those neurons later on in life, you have more to deal with from the get-go. So hopefully that delays the cognitive or the significant cognitive decline to further down the road. So risks for the dementia or the Alzheimer's, the family history of dementia is about a 3.4% risk. The family history of Parkinson's is about 2.4. Family history of Down syndrome is about 2.7. Maternal age of greater than 40 years is about 1.7. The history of head trauma with a loss of consciousness, about 1.8. History of depression, also about 1.8. Hypothyroidism, 2.3, which is interesting. That's about the same as the history of Parkinson's. And then history of severe headache even has a little bit of an influence, about 0.7. And then NSAID use is about 0.2. And so that kind of goes back to the thinking that there might be some kind of inflammatory process going on here. And so things like the NSAID use could indicate some inflammation in the body, also depression. They're now doing some research, or they're postulating that depression might actually be a symptom of inflammation as opposed to maybe, and like I said, this is still very new research, but they're thinking that it might be more along the lines of inflammation as opposed to imbalances of neurotransmitters. And they're thinking that the reason why things like selective serotonin reuptake inhibitors work, SSRIs work, is because they do have an anti-inflammatory mechanism too. But again, that's not standard literature yet, so take it with a grain of salt at this point, but I just thought it was interesting when I read that recently. The neuropathology of Alzheimer's, it's due to two minute things. It's the senile plaques that were seen in the picture previously, in the previous slide, and the neurofibrillary tangles, which was also seen in the slide. And so these combine to cause the disease. But what causes them? Good question. So inflammation around plaques destroys the nearby neurons. And these plaques, which are composed of the B-amyloid polypeptides, seem to, as a result of disorders in processing the beta amyloid, and its precursor protein. A combination of genetic predisposition and environmental influence is probably responsible. One influence may be ischemia, because patients with high blood pressure and increased cholesterol tend to have increased risk as well. The neurofibrillary tangles are made up partly with a protein called tau, and I think we mentioned tau earlier on, and I said I was going to get to that. Here's tau. So the neurofibrillary tangles are made up of that tau, which links to form filaments. And the density of the filaments within the neurons affects the severity of the dementia. So it's unclear why the filaments form, but the different alleles for a gene they're known to create forms of taus that are more likely to tangle. It's unclear if the tangles are related to plaque formation or not, but the tangles are known to compromise the microtubular functions and then lead to the destruction. Also, the involvement of cholinergic neurons causes levels of acetylcholine within the synapses to decline, and so the levels of acetylcholinesterase drop, perhaps to compensate for the loss of the acetylcholine. Activity of another cholinesterase enzyme increases, and a significant portion of the acetylcholine is metabolized by this enzyme as the disease progresses. So decreased levels of acetylcholine end up being a problem, and eventually the neuron is destroyed. So based on that concept there, if low levels of acetylcholine are causing progression of the disorder, then one would think it would be beneficial to replace some of that acetylcholine, or try to block the breakdown of the acetylcholine with in terms of the acetylcholine enzyme that helps to metabolize the acetylcholine and break it down. Ideally, we want to let it stay in the system. So here's just a slide that gets in a little bit more specifically to how the dementia develops in the brain. That one's fairly self-explanatory. I can read it out for you, but I have a feeling you guys can read this one by yourselves. There are some definite biopsychosocial systems that are affected by Alzheimer's. Significantly, social systems tend to break down. Basic ADLs start to decline at the beginning, but especially late onset and is greater than the loss of neurons. So as the disease or the disorder progresses, the symptoms that you see here start to decline even more significantly. So the social systems definitely start to decline. Psychological systems like the ability to form and recall memories initially are lost, and then later on the loss of the learned skills, such as the making the change with the money, or sometimes even the ability to function or work a doorknob is it becomes too much for these patients. There can be loss, or the neuronal memory systems can also change. And we got in a little bit to some of the changes in the acetylcholine, serotonin. So the neurotransmitters actually decrease as you get older, and so the way the brain stores and recalls memories can also change. So we talked about this a little bit earlier, but again, why would you want to diagnose Alzheimer's early? Ideally, so there are more choices available in terms of safety. You want to maybe consider stopping driving, making sure that there maybe is not as much in the way of gas range cooking as maybe microwave cooking. There could be some benefits in educating the family so that they don't they don't blame each other for some of the cognitive decline, so that they understand what to expect, they understand how to support their family member, and they can also talk about plans for the future in terms of where the patient is going to be living and at what point might it be time to go to a facility versus living at home. Ideally, you want to keep the patient in their home as long as possible, because the familiar environment, it makes life easier. When patients go to different environments, it can actually cause worsening of the symptoms, like we talked about before. Alzheimer's is still pretty frequently misdiagnosed. It's under-recognized and under-reported. Patient doesn't realize oftentimes what's going on, and families tend to compensate when there is a decline. So sometimes things can develop mildly to moderately even before it's recognized and the patient comes in for a visit. So the keys are to really, you want to get started on treatment as soon as possible. Consider the safety. You want to address the family's stress, educate the caregivers. Advanced planning while the patient is competent is very helpful. Not always possible, but would be great. So we need tools. We need to be able to assess for these cognitive changes. The screening tool of the mini mental status exam, like I mentioned before, that should be in your pocket at all times if you don't have it memorized yet. That should always be checked in the elderly population, especially with chronic illnesses, comorbidities, depression. This should be pretty standard for you so that you can check for cognitive decline pretty quickly as part of a basic office visit. Oftentimes they don't even come in for the cognitive impairment. They come in for one of their chronic medical condition visits, or they come in for just an acute visit, and you happen to notice that there might be something else going on, so you can just quickly do the MMA, well, the mini mental status exam. The other things you could do, though, tend to be a little bit more invasive and much more expensive, so may or may not be possible depending on the patient's funding, would be checking the CSF, the spinal fluid, for tau levels and amyloid levels. If the levels are low, that's a concern for the amyloid levels, or if the tau levels are high, that could be a concern. And then the PET scans can show you how the brain is functioning, and if there are areas of the brain that are not functioning as well, that would maybe show up in the PET scan. The nice thing also about the mini mental status exam is that it's just like the PHQ-9 or some of those other screening tools. It tends to enable you to be able to put a number to the sometimes vague symptoms. And so if you have a number each time the patient comes to the clinic, you do one of the exams or the screening tools, then you can watch a trend over time in terms of how they're progressing. I'm a big fan of objective things. I like to see those measurements. So just log this in the back of your brain somewhere. There are top 10 warning signs of Alzheimer's. And so if you happen to notice a patient coming in with concerns about any one of these things, then what are you going to immediately do for that patient? You're going to do that mini mental status exam. And then also, if it's more acute changes, then you're thinking, okay, is it maybe some delirium versus dementia, where there might be an actual reversible cause. So just keep this in the back of your mind if you're seeing elderly patients or patients with changes in cognitive function. Just be ready to do a pretty thorough workup. And dementia might be in your differentials. For the assessment, I know I emphasize this all the time, but know the history. Ask that history. You want to ask about family history, of course. You want to ask about the patient's history. You want to ask about the social history. Ask about history of head trauma. You want to be doing your physical exam. The physical exam may not actually reveal too much unless there's some kind of trauma or possibly abuse going on, but still, you always want to do it. You just need to always make sure to do that, the physical exam, not just the mental exam. The neurological exam, you're looking at, of course, memory, but also like language skills, because different areas of the brain, you can see in this picture here, on a normal brain, on the left, you have this nice gray matter that is nice and flush and mass, that has good mass. And you can see the language centers and the memory centers. But then if you look over on the right side, the patient with the Alzheimer's, the language center is very deteriorated. The memory center is also really starting to decline. And so those memory and language measurements can be very helpful in determining whether or not some Alzheimer's might be going on here. So again, know your history. Some of the things you will want to be asking are what were the first symptoms? What really made the patient concerned? When did it all start? What was going on at the time? That might help to find out if it's kind of more situational, maybe depression, like a family member died and now suddenly these symptoms are showing up. Maybe it's depressive elements. Compare now to how they were when they first noticed the symptoms to see what the progression of the condition is. This might require the presence of a family member who can be a better reporter in terms of what the condition was previously. Sometimes patients either aren't aware or not honest with themselves or with you, and don't oftentimes offer up the information that really helps you make that diagnosis. They're all really concerned. I mean, they're afraid. Some people know family members that this has happened to. Some people are afraid of becoming a burden, afraid of being dependent on other people, afraid of losing their independence. And so this can be a hard subject to broach with the patient, but also to properly address and find out that history. So use those great history taking skills that you're developing, because that's the bread and butter of diagnosing this. I mean, you're oftentimes, by the time you've done a complete history, a really good thorough history, and by the time you've done your mental status exam, you are probably going to have a pretty good indication already whether or not something is really going on in terms of chronic dementia. So like I mentioned, onset, duration, the course, this helps to rule out differentials from something that's more acute, like in the way of delirium, such as a urinary tract infection, constipation, that is spurring on these symptoms. You want to assess the level of the impairment, assess whether or not they're able to perform their ADLs. The bathe technique. See, we have you do the bathe technique for a reason in some, like in the SIM exam and in your monthly paperwork. It really is a good skill to have, and it's not just like what bothers you, what's bothering you, what's affecting you the most. It's really finding a way to make it a natural conversation within the conversation that's already occurring, but still you want to try to elicit that information. You want to get the information from the patient. And so I know it's hard, or it's annoying to have to put that in your monthly paperwork, but truly developing that bathe skill is really helpful in your career. want to check things like grooming. Have you noticed that they're becoming a little bit more disheveled? They're having trouble getting totally clean when they're bathing, or not maybe cleaning themselves all the way when they go to the bathroom. Are they having troubles with their gait now? Is there urinary incontinence just because they're not able to get to the toilet in time, versus maybe they are having a UTI, versus maybe they're just not cleaning themselves very well once they're done using the restroom. Medication history is also super important, because a lot of the drugs that we talked about previously can affect the cognitive function and affect symptoms of confusion. So remember, don't just ask, are you taking any medications? Ask, are you taking any over-the-counter medications? Sometimes patients don't think over-the-counters count as prescription or actual medications because they're not prescriptions. Ask, are you taking any supplements or herbs? Because some people don't believe that those are medications. Are you using alcohol? Are you using marijuana? Are you using illicit drugs? If you just say, are you using drugs, many patients don't think that marijuana is a drug. And so they might say, no, not using drugs, but they might be using marijuana, which can affect your cognitive function, whether some people like to admit it or not. It also has its benefits, so I'm not dissing on it, but it definitely can affect your cognitive function. And then in the elderly population, just think any medication or drug they're taking could potentially be the cause of the impairment. So you really need to think through the medications they're on. Really think, is there something in this medication that could be affecting the patient? Polypharmacy, huge in this population. Other things I talked about, like habits, alcohol use. See how that's not even in the illicit drug section? It has its own section. Alcohol, you really want to ask them how much they use and have them be specific. Oftentimes, just a couple. That's not really specific enough. How often are you? Is it once a day? Is it in the daytime? That's a concern. Are they doing any exercise? Are they smoking tobacco? In terms of medical history, it's like the head traumas, the loss of consciousness, concussions. Sometimes if wandering at night, they could fall and nobody could see it. Men tend to wander more than women. So again, if you have an elderly male patient, that should be maybe a little bit higher on your list of concerns for that patient. Family history, that one's pretty significant if the symptoms appear in middle age, or if a family member also had Alzheimer's at a young age too. And then, of course, heavy metal, lead exposures, solvents, and things. You want to make sure you're in ventilated areas, but that the occupational habits or hobbies can affect the cognitive function too. So when you do your neuro exam, remember you're checking all the cranial nerves. You're doing your mental status exam. That's the sixth vital sign. We're going to have 7,000 vital signs by the time we're all done if you're doing depression and everything else. But again, as appropriate per the population, the mini mental status exam, very useful. In terms of the cranial nerves, the olfactory nerves can see some deficits in Alzheimer's. There can be poor eye tracking as well in Alzheimer's. Sensory deficits, you're looking at things like possibly a B12 deficiency if they're just they're not sensing things in the same amounts at different points in the body, and they're having signs of confusion. You might want to think B12 for this patient. For motor assessment, you're going to do the Ames scale for tardive dyskinesia. You're looking for tone because rigidity could be Parkinson's as well. A slowed gait can be seen in Alzheimer's, especially later on in the progression of the disorder. You're looking at deep tendon reflexes. Focal abnormalities tend to suggest a neurological disease. Alzheimer's tends to have a very brisk reflexes, where instead of like 1+, you might be dealing with like 2+ reflexes. Pathological exam, you're looking at snout reflex, palmomental reflex, grasp reflex, maybe suggesting like frontal lobe dysfunction. Babinski's suggests more of a focal disease. These can all occur in late Alzheimer's, though. So that might give you more information just on how the disorder is progressing. So the current approach to assessing in the office or assessing the severity is the mini-mental status exam. So you can also do things like clock drawing. You can do animal naming for a minute. You can do the Mattis Dementia Rating Scale, Alzheimer's Disease Assessment Scale. You can just check their ability to perform ADLs. There's the Global Clinical Scale, Clinical Dementia Rating Scale, the Global Deterioration Scale. I mean, there's a bunch. There's a lot of different scales, and some of them are focused more on progression versus initial detection. And so you can maybe look these up, see if some might be more applicable at different times in the progression of the disease or the disorder, and you can just keep those in mind when you're dealing with a patient with dementia or Alzheimer's. But overall, and for at least initial detection, the mini-mental status exam is pretty darn good. It has a sensitivity of about 71 to 92%. 92% is pretty good. So that means that it will correctly detect a patient with, or it'll find a patient with Alzheimer's correctly 92% of the time. It has a specificity of 56 to 96%. So that means as little as 4% of the time, you could get a false reading that a patient might be or might have Alzheimer's but not really have it. So it's pretty specific. I mean, if you get some concerning results with the mini mental status exam, you're pretty good in assuming that that it's probably due to some kind of dementia or delirium. And the PPV is about 15 to 72%. So it's a very simple screening tool, but it's actually very, very useful. So again, this is one of your best tools in assessing the cognitive function in your office. I mean, of course, there are other tests you can do, but those are more costly. You can do the labs, you can do the scans, and the like. But what you can do right there in the office for your patient, totally free, is do that mini mental status exam. And so this shows over time the cognitive decline in the patient's ability to perform these specific skills. You can see it goes about 10 years out. They don't go much beyond 10 years because of the fact that after about 10 years, these patients really are not doing very well, and unfortunately, some may be dead and some are unfortunately very, very affected by the disorder. But you can see all the different colored lines. They all have pretty steep declines in level of function over time. Some other scales used in the management of Alzheimer's disease. Feel free to read these, look them up if you would like. They have varying degrees of usefulness and different purposes. So if you're looking for behaviors, like disturbed behaviors, you could use the neuropsychiatric inventory. If you're wanting to measure just levels of cognition, the Alzheimer's disease assessment scale might be, or the cognitive section might be more useful. And then of course these tests or these scales take varying degrees of time to do as well. Some of them are just like 5 to 10 minutes, but like the Alzheimer's disease assessment scale, that's 20 to 45 minutes. So much more demanding in terms of the time for that one. So use as appropriate and use for whatever you are trying to kind of determine for that patient. Lab tests, I had mentioned this before. Some of these are most of these are actually to rule out other possible causes of the cognitive impairment. So let's say you've done your history and your physical exam. Now you're thinking about differentials. This is what will help you rule out some of those differentials. So a CBC and a SED rate. The CBC can maybe show you a little bit about anemia. It can show you, the WBCs might be able to show you about active infections. SED rate also infection or inflammation. The chem panel looks at how the liver is doing. If you're thinking about hepatic encephalopathy, maybe you have a fasting blood glucose. So if you're concerned about diabetes and blood sugar issues, that could be done there in the office even. You want to be doing all the thyroid tests, so that's like the TSH, the free T3, free T4s. There are actually even more specific tests than that, but I mean that's a good start. You're doing the RPR maybe to rule out the syphilis, like I mentioned that patient that I had been dealing with. The B12 level can be helpful if you're thinking about pernicious anemia, maybe a folate deficiency. And then depending on the symptoms, like let's say a patient is having significant respiratory infection or cough, you would be doing a chest x-ray to rule out pneumonia. An EKG could rule out maybe some cardiac involvement to a certain extent. CT scan can also show if there are signs of ischemia maybe going on in the brain. And like I mentioned, a UA also very helpful because many times the cognitive decline is due to a UTI that does not present the same way in the elderly population that it does in the younger population. And if you have clients with risk factors for HIV especially, and they're experiencing dementia at a younger age, HIV is also good to do. I did that for the patient that ended up having the syphilis, and luckily the HIV was negative. Of course, doing all these tests is not terribly cost effective, and so you don't do them all for every patient that comes in with dementia, but that's where your really good history comes into play. You ask really all those important questions that will help you rule out some of the differentials, and if you're getting some possible differentials, then you would take the next step and order some of these tests based on what they've told you in the history, but also their current presentation. Some other diagnostic tests that can be done, or these are much more costly, so they may or may not be done. It depends on the desires of the patient and the family, and also the funding available. I mean, if their insurances won't cover it, and I mean these are expensive tests, and so it's just good to be aware of the costs of tests before you start ordering a ton, because if the patient is not able to afford them, you're maybe causing more harm than good. And sometimes you can maybe get to the bottom of it or come up with a possible or a legitimate diagnosis even without doing a PET scan per se. The CSF analysis I mentioned you could do before. It's rare, but you could look for things like low amyloid, or you can look for high tau. There's also, you could do like the EEG to maybe rule out a seizure disorder that might be causing symptoms similar to dementia. The genotyping you would do if a patient under the age of, or around the age of 60 is showing signs of this, or if there's a family history of dementia. That's where this tends to kick in and become something worth checking. Here are just some nice pictures. With this one, I say nice because this is a 73-year-old male with some PTSD, but look at the mini mental status exam. You're looking at a 30 there. So this is a cognitively present and capable patient. You look at the brain itself and you're seeing it light up with pretty well with normal activity. There's a good mass there, good size. I mean, this is for a 72-year-old, this is a pretty decent looking brain. This is just, doing these scans gives you more objective evidence. I mean, you, with your history taking, with your physical exam, with your mini mental status exam, you're pretty much there to a certain extent on your diagnosis. But the objective evidence is important. It can help support your diagnosis. So again, if the patient can afford these tests, then maybe it's worth doing. Now we get to the second patient here. This is an 83-year-old male. Now look at the brain activity. It's not firing as well. You have the nice flush, full red firing there. This one, the red area is not as massive, and it tends to be not as well lit. So the activity there is diminished. The mini mental status exam now on this patient is 16, so you're also seeing some cognitive decline in this patient. So this is probably like maybe early onset probable Alzheimer's disease. Now the last one, boom, suddenly a lot of the tissue is now deteriorated. You're seeing a pretty significant decrease in brain activity, decrease in the mass of the brain. This is very late stage Alzheimer's. I mean, this is very, very probable Alzheimer's disease right here per the scan. So here's a PET scan. In early stages of Alzheimer's, most of the areas of the brain are still functioning really well. You're still seeing good firing. As the disease progresses, though, then you're starting to see decreases in the lighting up of those areas. In terms of management, luckily I was able to find a newer article. Is this the newer one? I might have included the management in a slightly later slide. There's I think that I've included a newer article than this one even on a later slide. But you can check this one out and check out the new one, see if there's any changes in there. Sorry. Anyhow, the goals here are twofold. You want to try to eliminate the use of unnecessary meds. Give them only the medications that are really crucial, because of the fact that so many different medications can have an effect on the dementia symptoms. The other goal is to treat the comorbidities. You want to make sure that you're not neglecting the other conditions the patient has because you're focused on the dementia, or you're assuming, okay, well, now that there is this decline here, they're moving toward an inevitable outcome, and so maybe we don't have to be as aggressive with the other things. The truth of the matter is, you want to try to treat some of those other comorbidities like diabetes, like cardiovascular issues, like COPD, whatever the case may be, because the symptoms of those disorders can actually exacerbate the dementia. So you do want to continue to properly address the other medical morbidities that this patient could be experiencing. And management of Alzheimer's really is within the scope of care of a nurse practitioner. But again, especially if it's a new onset Alzheimer's or a newly discovered Alzheimer's, maybe it's complex, there might be more than one thing going on. It's an early onset, like before the age of 60, or there's presence of other things like Parkinson's symptoms, then you would want to maybe get that patient referred more quickly. The 2 points of emphasis for the management are, of course, drug therapy, and we're going to get into the drugs a little bit in just a little bit. And then the other thing is, of course, the client/family/caregiver education and support. You want to help to provide the group, the family, the patient, the caregiver, with as much information and education and resources as possible to be able to seek and achieve the best outcomes and have the best possible care per their means. And I just mentioned this a little bit, but you don't want to think of the patient as a single entity. This patient is really, think of it like a pregnant mother. I mean, it's not just the mother you're dealing with. You're dealing with the fetus as well. You're dealing with the family. And so it's this whole unit. And you want to think of an Alzheimer's patient in the same manner. You're really wanting to provide that education. You're helping them prepare for the future. You're helping to give them the resources necessary, or connect them with the resources necessary to really try to tackle this disorder. The acetylcholine, is the mainstay treatment modality. There are kind of three common ones that are used. The goal is to either increase acetylcholine or decrease the acetylcholinesterase. The three drugs that are commonly used in terms of the acetylcholine are the donepezil, the rivastigmine, and the galantamine. These meds have fairly low risk of serious side effects, but can have cholinergic effects. Not the anticholinergic, but the cholinergic effects, such as they can experience nausea or anorexia, they can be vomiting, they can have diarrhea. And the good news is, though, if you start low and go slow to a certain extent, you can try to avoid these side effects, and patients can often develop a tolerance to the side effects over time, which can be helpful. They might experience some of those nausea symptoms initially, but over time they can kind of start to acclimate and not have that in the future, even though they're still on the medication. If you do, for some reason, if the therapy is interrupted for a couple days or more, then unfortunately you have to restart the medication back at the lowest dose and then titrate back up to the level that you would desired. Just because once there is a break from the medication, the susceptibility to those side effects kind of starts back over, and they could, when they restart, be unfortunately susceptible again. And if you start at the highest dose, then you're going to make your patient pretty sick, possibly. So again, the mainstays are the acetylcholinesterase inhibitors, and those are basically used to treat the cognitive impairment from mild to moderate dementia. They don't totally halt it, but tend to delay. And that's, when I talked about it earlier, I had mentioned that the acetylcholine seems to be a major factor in the deterioration or destruction of the neurons. And so if we're able to do something that either that basically allows more acetylcholine to remain in the system, then hopefully that will slow the destruction of those neurons. But again, you want to watch out for the cholinergic effects when you use those medications. They have modest clinical effect on the status. Sometimes initially the patients do show some improvement, but then there tends to be a slow decline after that. Tends to be a lot slower than if they were not on the medication. So it tends to improve overall their level of functioning. They might need less focused care, and sometimes then also they can spend more time in their own home before the care required becomes so significant they need to go to a facility. The memantidine, I think Namenda it's called, is another category of the medications for Alzheimer's, and this one actually, for moderate to severe is used in combination with the the Aricept or one of the other anticholinesterase inhibitors. The memantine is a glutamate receptor antagonist. Glutamate is an excitatory neurotransmitter, and unfortunately it can destroy damaged or vulnerable neurons. Blocking the glutamate receptors prolongs the survival of the neurons because they're not sucking up the glutamate like they would be. The studies are showing that the Aricept and the memantine are more beneficial than just the Aricept alone. So that's why it's used in the more moderate to severe cases of the Alzheimer's. There are some other medications. I think this is the more current treatment or medical management article. Yeah, that is. This is the one from 2011. So if you want to look at a more current article, that's a good one for the medications to use for Alzheimer's. Some other medications like the alpha tocopherol. There's some early evidence showing that's pretty good. I haven't seen it used too much, but just wanted to let you know that it's out there. The efficacy of ginkgo biloba really is not terribly well supported, and so I have not necessarily recommended that for my patients with Alzheimer's. Some other medications to think about are more for other concurrent symptoms, such as like the behavioral disturbances. If a patient with vascular dementia and Alzheimer's is struggling with some behavioral disturbances, there are some medications you can use. About 80% of the patients with both those dementias have behavioral disturbances. And so some of the medications you can use there for the trouble sleeping, you can use trazodone. It's fairly useful in terms of the sedation, especially for patients that are dealing with anxiety toward the evening. So maybe along the lines of maybe sundowning, that might be a possibility. Some atypical antipsychotics at low doses can also be useful. And so something like Risperdal at just a very small dose, like a 1 milligram or even half a milligram, tend to improve some of the symptoms of psychosis and aggression. The atypical antipsychotics can be useful also for like sundowners or maybe people who like to wander. Men especially, like I mentioned before, tend to be wanderers. The downside to these atypical antipsychotics, though, is that there's a slightly increased chance of mortality in the older patients. They're thinking that's due to the fact that there might be an increased risk for cardiovascular or infectious causes, maybe due to like a prolonged QT interval or due to the sedation. But again, you're looking at quality of life, you're looking at quality of life for the patient, you're looking at quality of life for the family unit and the caregiver as well. And so sometimes these medications can be truly beneficial. These are the medications that I mentioned before. These are all FDA approved for the treatment of Alzheimer's. And then I also mentioned the Namenda as well, and that one can be used in combination with like the Aricept for moderate to severe Alzheimer's. Some of the medications to avoid, I have mentioned some of these before, like the OTC meds, like the diphenhydramine, also tricyclic antidepressants. They can exacerbate the sedation, confusion, or dementia, along with causing dry mouth and constipation, which are signs of or symptoms of dementia. So I do not recommend doing something like Benadryl at night for patients that are struggling to sleep with dementia. And if you are going to be treating a patient for depression, I would also stay away from the tricyclics, go more with like either an atypical antipsychotic, or I guess you could try like an SSRI or even the trazodone. again, I mentioned this one too. The client and family education and support is very, very important. You want to try to explain it without as much medical jargon as possible, trying to present the information in such a way that patients from any level of education can hopefully understand what's going on, caregivers and patient alike. The goal is to help the family come up with a plan for ways to move forward, both in terms of medication and ways to deal with the progression of the disorder in the household, and then when to transition to a higher level care facility later on. There is some there's some literature kind of going either way in terms of whether or not to tell the patient themselves. I am always a fan of giving the patient and the family as much information as possible. And some cultures actually don't want you at all to say to the patient. So you have to be careful of who has the power of attorney and who is making the decisions, because if if the the family doesn't want you to tell the patient, you need to be aware of who you need to really be listening to in that environment, because you could possibly be causing more harm than good culturally by telling the patient. Although I do try to educate as well as possible and try to inform everyone involved, as long as it's culturally appropriate. You do want to work on the future plans, and then you want to involve resources and support. There are a lot of Alzheimer's resources in local communities, and so make sure you're aware of, when you get to the place where you're going to be practicing in the future, make sure you're aware of what resources are available, so that if you do need to make referrals or connect your patients with these resources, you have it ready to go. Kind of the keys here: keeping the patient at home as long as possible can be great if the family is able to support that, just because the familiar environment tends to help the patient. Unfamiliar environments can sometimes make symptoms worse, at least temporarily. Sometimes you can do like a combination of board and care and home care, but typically eventually the disorder progresses to the point where the patient might need to go to a facility that specializes in Alzheimer's. Other things to think about in terms of patient safety: you want to educate on ways to set up the household to help the family prevent injuries. You want to help keep up skin care, be aware of the incontinence, help the family cope with some of those changes in bodily function. The referrals, like I mentioned, are super important. And some families, even though you've already made the diagnosis, will want to go to a higher level, and so you can refer them. That's totally fine if that's what they request. Sometimes the family might also need referral to a genetic counselor should this be an early onset Alzheimer's and you are concerned about genetic involvement. Okay, so this is our last slide. Just want to leave you with some of the tenets of Alzheimer's care. You want to try to establish the diagnosis early, because that leaves options available. You want to do a thorough assessment, and that includes a very thorough history. The history, like I've mentioned before, is pretty much key to most of the disorders we're talking about in this course. And as you gain experience as a practitioner, you're pretty much going to narrow down your diagnosis and maybe a few differentials by the time you've completed your thorough history. And then the physical exam and any other labs that you do are really just to verify what you've already kind of narrowed it down to. So again, working on getting that great history is very important, especially as you're starting out. Think of the client as the unit, the triad. It's the client, the caregiver, and or family, if the family's involved. The education for everyone involved is crucial, not just in terms of what to initially expect, but also what to expect down the road. You want to try to get them involved with as many support sources as possible, so that they can have access to the care, and they can have access to hopefully medications, and then down the road possible facilities that might be able to help support them. The behavioral environmental interventions, so behavioral could be other medications to support some of the symptoms the patient is experiencing. Environmental interventions are ways maybe to decrease stress, to keep the environment familiar, to keep the environment safe in terms of not putting the patient in a situation where they might get out of the house and get lost, or maybe get in a car and drive, or leave the stove on and start a fire. So all these things need to be addressed with the triad, that unit, the family, client, caregiver. There are medications that can be used. They slow the progression of the disorder. Unfortunately, they don't completely halt it. There really are no easy answers. This is a family journey. Everyone in the family, including the caregiver, go through this process together with the patient. And so the key is to be supportive, be an advocate, and educate like crazy. The better you arm your patients with the information, the better they can hopefully function, and hopefully the better the quality of life for that patient as the disorder progresses. And then, just as a quick reminder, we've spent the majority of the end of the lecture talking about dementia and Alzheimer's, but there are some other disorders that can cause similar symptoms, and so you also do want to be thinking about the depression. You do want to be thinking about possible delirium and what might be underlying that's causing that delirium. And also, please don't just assume, if you have a patient that has a pre-existing diagnosis of dementia or a pre-existing diagnosis of depression, that the symptoms that they're exhibiting are due to those pre-existing conditions. You still want to do your due diligence and really work up the patient to try to rule out whether or not there might be new things that could be contributing to the cognitive impairment. Okay, well, you guys made it. I believe that's it. So very nice work, and I hope that you found some benefit out of that. Feel free to contact via the weekly question or discussion board if you have any questions or concerns. Alrighty, thank you.